So let's talk about the current guidelines imposed by government or international organizations. Can you just give us an overview of what the guidelines are and what might be some of the problems with them?
So the guidelines haven't really changed very much since the beginning. In fact, even since before the pandemic. So of course, we wash our hands and we maintain social distance from each other, and there's even fairly strict prescriptions on that. But otherwise, for the airborne transmission route, quantitative guidelines have yet to fully emerge. And it's in fact critical that such quantitative guidance be accepted and be advocated by these agencies, because momentous decisions are being made in the lack of such guidelines based on either arbitrary assumptions or strict adherence to the existing guidelines, such as the 6-foot rule.
But there's certainly an emphasis on social distancing.
Yes, there's a very strong emphasis on that. So what we will find through the analysis is that when masks are not worn, that can actually provide a significant measure of protection from respiratory plumes that are emitted by people's breathing. But when masks are worn, that mode of transmission is significantly reduced, and airborne transmission in the room beyond 6 feet can become much more important, and social distancing measures become less important.
So simply keeping distance may not be sufficient in some cases.
Indeed, it may not be sufficient in some cases, and in other cases, it may not be so necessary. A good analogy that I think many people can identify with is to think of smoking. So if you think of the problem of secondhand smoke, where there's one smoker in a room and you're concerned about whether other people in the room will be breathing in significant amounts of smoke for significant periods of time. So you can kind of think of the smoke particles like pathogen or virion-bearing droplets. So there's obviously an important distance component to that. If the person is breathing directly, we can see the plumes of smoke that are emitted when the person breathes out. And if you find your face, as a susceptible person, right in that person's breathing plume, then that could be a rather high concentration. But very quickly, it's also being spread all around the air. So someone who is sitting at another table in that room or another side of the room can certainly see the smoke and also smell it and breathe it in. And it's not protected against by any social distancing measure. So the idea of sort of blocking ballistic droplets, with face shields or other plexiglass shields that you find, for example, at the supermarket, give a false sense of security, because people who are transmitting the disease are typically asymptomatic. And it's sort of like, when's the last time you saw somebody cough, with COVID-19? So people typically remove themselves during a pandemic when they have symptoms. Okay. They're not having these violent expiratory events such as coughing or sneezing, but instead are just breathing normally, speaking, and so they're definitely emitting droplets and transmitting, but in such a way that then sort of enters the room, swirls around in the air currents, and can easily go around shields and reach essentially any part of the room. Evidence has been mounting for airborne transmission in particular, and yet the CDC and the World Health Organization have been, you could say, slow to accept that. So initially, when the possibility of airborne transmission was first raised back in February or even in January, and then some epidemiological evidence was mounting from various super spreading events into March and April, there was a lot of resistance to accepting this as a mode of transmission. So back in June, a open letter was led by Lydia Moravska and Donald Milton and other concerned scientists, was published, which pointed to what they call the reality of airborne transmission of COVID-19 and the need to develop new guidelines to fight against it. So those scientists have been having an impact, and I am trying to join the chorus of voices which is saying the same thing, but that once you acknowledge airborne transmission, you have to recognize that the means to fight it cannot be imposing a bound on a single variable such as occupancy or distance between people, a social distance, or even ventilation rates or filtration rates, because all these variables are linked. And so the goal of my research and other scientists' contributions in this area is to try to come up with quantitative guidelines to say, as a function of the various parameters in a certain space, the number of people, the ventilation, the size of the room, etc., what is the actual risk? How long can people spend in that room? How many people could be there? And really quantifying that risk in revised guidelines.
So how would you order the effectiveness or importance of these different measures?
So based on the analysis that we will review in this class, it will become clear that mask wearing is the most effective and cheapest and most easily deployed method of curbing the spread of the pandemic. After that, we certainly need good ventilation. So where possible, high exchange of outdoor air is important. After that, the next most important would be filtration. So you can sort of buy yourself some additional safety by either filtering through the ventilation system or installing freestanding HEPA filtration units, for example. And then finally, the size of the room is also a factor. So larger rooms are better than smaller rooms. Lower occupancy is better than higher occupancy. And obviously, shorter times are better than longer times.
So in your opinion, would it be sufficient if we, since we're talking about ventilation, can we just put a number on ventilation and say we need to have this level of ventilation? Would that be sufficient?
So it's tempting to do that, and certainly widespread adoption of guidelines is easiest when it's just simply a limit on a single parameter, such as occupancy of 25 or of 25 people, or social distancing of 6 feet, or a ventilation rate minimum outdoor air at, let's say, 8 air changes per hour. So while it would be wonderful to have such high ventilation or higher in all spaces, that may not always be realistic, and one must consider the cost and the difficulty of implementing measures such as filtration or ventilation against the benefit in saving lives and curbing the spread of the disease. The same goes for occupancy requirements and social distancing, because that can lead to, for example, closures of schools or businesses, with many other consequences that need to be weighed against the benefits of enforcing those guidelines.
So time plays a role in all of this as well, right? So for example, if I have daily contact with the same group of people over a long period of time, how should we think about that?
So time is a very important variable, which in fact has been left out of existing guidelines, aside from the 15-minute rule in contact tracing. So the time that enters the guideline is not necessarily just a continuous time for one infected person to enter the room and then eventually leave. It could reflect the average time that an infected person might stay in the room based on people coming and going from that space. It can also represent repeated exposures over longer periods of time, for example, days where certain people spend a certain number of hours per day with the same group. So it can be a cumulative exposure time. So for example, in the case of a classroom or a business, we have essentially the same people seeing each other each day for a certain number of hours per day, and so the time is the accumulation of only those hours. However, it does end up extending over days, and that's where testing and recovery come in. So of course, if people spend arbitrarily long periods of time together in the same space and one of them is infected, there's a good chance there could be transmission. But that time gets cut off by essentially any way of removing the infected person. One of those ways is by the infected person leaving that space. Another is by the person recovering. The person could also pass the incubation time and get symptoms and then remove themselves, or be removed by a detection of fever or of other symptoms, even that they may not be fully aware of. And then also testing. All those, the frequency of testing also gives you a limit where you know that people can't go more than a certain period, before, let's say a week, if you're testing weekly, before that person, the infected person, would be removed.
Okay, so let's talk about some specific establishments, such as schools, nursing homes, and restaurants. So how should we think of them differently?
So if masks are worn and short-range transmission is largely cut off, and we're focusing on airborne transmission through the well-mixed room, that we could essentially return to normal activity in many cases, where we do not impose strict social distancing of 6 feet, or even necessarily 3 feet, although social distancing would always be preferable. And essentially, if the guideline allows it, based on airborne transmission, and the ventilation rate in the room and all these other factors, it could be possible to return to normal occupancy in a lot of spaces. Conversely, in other cases where masks are not worn, for example, in a nursing home where a person's having trouble breathing and is just, compromised in various ways and can't be spending every minute wearing a mask in their own home, in their own bed, then they are at much greater risk. And also in homes, nursing homes, but also other private homes, where people are spending long periods of time together, frequently not wearing masks, there's a much greater risk. What I want to emphasize is that that risk is not adequately captured by social distancing or 6-foot rule, but in fact, you have to, the airborne transmission route can become dominant, especially over long periods in an indoor space. And so to take that into account, we have to develop a quantitative guideline, as we're going to be discussing in this course, to understand how the various characteristics of that room can lead to actually making it safe, as opposed to, say, moving the beds 6 feet apart and just being near each other for several weeks, let's say, not wearing masks. That's obviously not going to be safe. Restaurants are another difficult situation because obviously you have to take off your mask to eat. And also people enjoy eating together when they can face each other and have a conversation. So they're speaking and eating while facing each other at a fixed distance and constantly breathing in the same direction. So that can maximize the risk of short-range transmission, which also needs to be considered. On the other hand, even for restaurants, good ventilation and air filtration, again, making use of the guidelines that we'll be teaching here, could mitigate that risk so that it is possible to engage in eating at restaurants again.